Let's have a look at iron deficiency anemia with updated approach. Iron deficiency anemia is a common disorder you encounter in medicine OPDs.
શરૂથી કહો હું તકલીફ થતી હતી તમને બોલો તો ખરી હું તકલીફ હું થતી હતી માથામાં દુખતો હતો
માથામાં જ દુખવાની તકલીફ છે.
બીજું અંધારા આવે ચક્કર આવે એવું કઈ હતો
એવું જ થાય સાહેબ. ચક્કર આવે આતા પેન ચક્કર આવે હડવાનું એ નહીં થાય.
બરોબર જીભ
ચક્કર આવે પરિસ જો એમ જ લાગે.
જીભ બતાવો બરાબર.
Now, what are the causes for iron deficiency anemia? It may be due to physiological or environmental causes. Physiological causes like pregnancy, infancy, rapid growth phase in adolescents, especially in growing females. It may be due to menstrual blood loss or blood donation. Now, coming to the environmental causes, it may be due to insufficient intake, malnutrition, or diet like in vegetarian, vegan, or iron poor diet. Now, coming to the clinical presentation of patients, patient usually present with non-specific complaints like fatigue, irritability, decreased exercise tolerance, and there are signs you can notice in patients like chiliosis. Chiliosis refers to fissures at the corner of the mouth, angular stomatitis. Koilonychia, that is spooning of the fingernails, and palmar creases gets lighter in color as compared to the surrounding skin when the hand is hyperextended, and it refers usually HB is less than 8 gram per dl. There are other clinical features like pica. Pica means craving of known food substances. Patient जैसे मिट्टी खाना शुरू कर देता है, and restless legs, and there may be precipitation of heart failure. Maybe atrophic glossitis can also be noticed in patients of iron deficiency anemia. Now, coming to diagnosing a case of iron deficiency anemia, first of all, you will get an CBC with peripheral smear done along with the iron indices. Now, first let us talk about the stages of iron deficiency anemia. There are 3 stages of iron deficiency anemia. First one is negative iron valence, then iron deficient erythropoiesis, and ultimately iron deficiency anemia proper. Now, in negative iron valence, you will notice as demands and losses are more as compared to iron absorption. So iron mobilizes from the iron stores, that is from the bone marrow and from the liver. Then comes iron deficient erythropoiesis. Here you will notice serum iron starts to fall and hemoglobin synthesis will be impaired, and ultimately iron deficiency anemia. Here hemoglobin falls as well as RBCs will become microcytic hypochromic, and you will notice poikilocytosis, cigar or pencil shaped foam cells. Now, coming to the CBC, when you will look at CBC report of a patient, then you will notice there will be decrease in the hemoglobin and decrease in hemoglobin indices like decrease in the MCH and MCHC. You will also notice decrease in the hematocrit, RBCs count will decline, and red cell distribution width will increase. And when you will calculate the reticulocyte production index, it will be on lower side as it comes under hypoproliferative anemias. Now, coming to iron indices, you will particularly look at serum iron, TIVC, and serum ferritin. Now, serum iron normal values is 50 to 150 microgram per dl, and TIVC is 300 to 360 microgram per dl, and serum ferritin is 50 to 200 microgram per liter. Now, you will notice first of all, serum ferritin starts to fall as patient land in negative iron valence. Then TIVC also increases initially, and serum iron levels remain normal in negative iron valence. Then coming to iron deficient erythropoiesis, here serum ferritin levels will further decline. Now, coming to the treatment part of iron deficiency anemia, it is treated with RBC transfusions, oral iron or IV iron. RBC transfusion is reserved for patient with severe anemia, that is lesser than 7 gram per deciliter. One blood that contains 300 to 350 ml of blood, it provides 250 mg of elemental iron, and it can be also given to patients with heart failure up to 10 gram per deciliter of hemoglobin if patient is in heart failure. Now, in day-to-day daily life and in OPDs, we are treating patient with the oral iron. So, an adult requires 100 to 200 mg of elemental iron per day, and there are various preparations available for in oral iron like iron ascorbate, iron ferrous ascorbate and ferrous fumarate. Now, according to the latest treatment protocols, we should prescribe only single dose for iron, and that too on alternate day. This is to decrease the level of hepcidin. Hepcidin, as you know, it will block the ferroportin transporter in duodenum. So if you will prescribe repeatedly in regular doses of oral iron, it will lead to increase in hepcidin level. That will further block the ferroportin transporter, and that will not allow iron to come out of duodenal cells to the blood for the absorption. So better to prescribe iron as single dose, and that too on alternate day. Now there are various challenges with oral iron replacement. As patient may have metallic taste, patient may have heartburn, abdominal discomfort, constipation. There may be associated persistent nausea, vomiting. So if patient does not tolerate oral iron preparation, then we switch on to IV preparations of iron. Talking about iron sucrose is usually given in 200 to 300 mg per day. You can give 200 mg iron sucrose diluted in 250 ml of NS over 1 hour. And then coming to FCM, that is ferric carboxymaltose, usual dose is 750 to 1000 mg, that you can give over 15 minutes diluted in 100 ml of NS. This is how we treat an iron deficiency anemia patient commonly in OPDs. Now an important note, iron should be avoided in first trimester of pregnancy, both IV iron as well as oral iron. It may lead to fetal abnormalities. Thank you.